Hello, everyone. It's Lacey with the Your Lyme Matters podcast, and we're very fortunate today. We are joined by Terri Fox. Hello, Terri. Welcome.
Hi, thank you for having me.
My pleasure. First off, we have a SIRS and mold expert here with us who is also Lyme informed. So we've got a really awesome mix of experience. Terri, where are you signing in from today?
Sure. So I'm in Boulder, Colorado.
I'm going to just ask you, what made Terri say, I want to become an MD?
I was living in Guatemala in my early 20s, working with street kids and orphans. And I was in charge of healthcare and health education. And I had a bunch of med students and residents and physicians come down to volunteer. And they would always work with me in the field. And so I got inspired and had some really great mentors.
And it's super helpful to pull into your practice, I'd imagine. Okay, so that's what kind of prompted you becoming an MD. Now, what prompted you to delve into functional medicine world? And can you tell people just a very little summary about what functional medicine is in comparison to regular medicine?
Yeah, sure. So I was always more interested in the holistic, integrative approach. I probably would have preferred to go to naturopathic school, but I figured if I could get my MD, I could integrate the rest and, be able to do a lot. And so I did a board certification in integrative and holistic medicine after internship. And then I studied functional medicine for a long time. And functional medicine is looking for the underlying root cause or dysfunction as opposed to treating each symptom. So in allopathic medicine, there's a lot of like high blood pressure, atenolol, and then high lipids and a statin, and you just treat all of those things separately. Whereas functional medicine is trying to find what is the underlying root cause of each disease or symptom.
And then what prompted you to delve into Lyme and tick-borne infections?
I grew up in Virginia. Lyme is endemic. Everybody I knew has had Lyme. And so I had a little experience there. My older brother had gotten it and got real sick. And then basically my son got really sick. He was 8 years old and he was a really active, thrill-seeking, maniac little boy, like a lot of 8-year-old boys are.
Yeah.
And he's just started limping out of nowhere. And I would ask him if his knees hurt and he would say no and then he'd walk normal. But when no one was looking, he was limping. And then he started getting anxiety and kind of panicky, which was very unlike him. And he put on a bunch of weight. He was stiff after car rides or in the morning. In the mornings, I knew something was wrong and I didn't want it to be Lyme. So I tested him for everything else in the world first. And then he turned out to have Lyme. And I took him to see Dr. Stephen Harris, who's now, I think, the president of ILADS. He's amazing. And thank God he let me bring him in. And he gave me a urinary mycotoxin test. And we did it, and his mold was through the roof. So at that point, we knew there was something else going on, and we had our home evaluated, and he got really, really sick before he got better. And so that's how I, sort of dove into the whole biotoxin world of Lyme and co-infections and then mold. And I didn't know anything about mold at the time. Yeah.
So that answers what prompted you into the mycotoxin world also then. Yeah. So your family was touched by it, and then that probably fueled your passion for it even more, especially having a kiddo with it. Hopefully things are smooth symptom-wise for your child now, but
he's great. Yeah, he was
awesome.
He got better when we got out of the mold and pretty quickly, and yeah, he's 100%.
Yeah, he's also got mom to come to now with questions in the future if anything comes up too, and a very trained mom as well, very, very well versed. So handy. Right. Yeah. Okay, well, thanks for sharing that with us. It's always nice to know a bit of what prompts people into this super, super niche area of medicine. And I will give props to the practitioners because I have the patient and I'll be eventually coming into the professional world of it. This is some of the most complex medicine I've ever seen. And for the patient perspective, it's some of the most severe comorbidities and very challenging things that come with it. So I appreciate the practitioners. I can see their brains watching them, the complexity of the layering, and I'm sure we'll get into some of that with how you treat patients. So I have a lot of appreciation for that. You mentioned a few of your background trainings. You have functional medicine, you're Lyme informed. And did you do additional training for Lyme disease in particular? Your ILADS informed?
I did a bunch of ILADS conferences, and then I did Dr. Horowitz's invite-only practitioner training.
Now let's getting into the heavy content of this, because it's a very complex issue, mold and SIRS, just so people who have no understanding, what is SIRS, what is mold illness or mold colonization, like what is the difference would be super helpful for us.
To be honest, I think they're one and the same. So SIRS is chronic inflammatory response syndrome. And that's sort of what happens from mold illness and mold toxicity. They're pretty interchangeable, the words. There is sort of two different camps of the way that we treat mold. And one is a little bit more the old school shoemaker kind of SIRS world, and then more like the Neil Nathan and Dr.
Krista?
Yeah. All of
Yeah.
them. And I think most of us integrate all of it. I integrate both, but I use the terms interchangeably, mold illness or SIRS.
Can you tell us what symptom differences there might be, or are they one and the same?
For me, they're one and the same.
And you said SIRS is kind of, in your opinion, a result of mold or endotoxin exposure, so they kind of go together in that way. Is that what you mean?
Yeah, so mold toxicity creates chronic inflammatory response syndrome. So there's an inflammatory pattern that happens with mold, and you can sort of see some of the markers for that. And it's sort of a pattern that points to mold, but the symptoms are the same. They're both mold illness.
It's there's, as you mentioned, two schools of thought. It's good to have someone who has the experience on both of those. In your experience, do some people who do a SIRS treatment go on to need some aspects of mold treatment? But for those who might go to someone who just has one or the other, have you heard if some may not fully resolve and may need parts of both, or where do you stand on?
Yeah, but my lens is distorted. So I get the patients who didn't do well with just the shoemaker protocol and didn't get better, or they got partially better. So I think what you're alluding to is the colonization aspect. And so when you start treating mold, I do it in two different phases, phase 1 and phase 2. Phase 1 is training the body how to detox, metabolize, and get the mycotoxins out of the body. The people that get sick from mold are the ones that can't metabolize it, detox it, get it out, and the urine, the stool, and the sweat. And so it just builds up in the system, sort of filling your internal bucket. And so the first whole part is binders, glutathione, that sort of thing, to help begin teaching your body how to pull them out and begin lowering that total body load. If somebody gets 100% better on phase 1, they don't need to go to phase 2, which is antifungals and biofilm. And so that's where the colonization comes in. So if they didn't colonize, you can pull out, and colonize means to live in you. So if you've been in a moldy house and you breathe a mold spore up into your sinuses or swallow one down in your esophagus, it can stick and live and replicate and create communities and biofilm and all of that. And that's called colonization. So at that point, the mold source is actually within your body, no longer just in your house or your environment. But the people that have colonized are still going to be producing mycotoxins within their own system.
Okay.
And so if the mold isn't killed in their body, then it's sort of like a boat with a hole in it, and you're just bucketing out the water forever and ever, and you're never going to finish.
Yeah, that analogy really hits that home for me. Yeah, you're behind the ball the whole time then.
Exactly. Yeah.
From hearing that just right away, it sounds super helpful to have background in both of those, exactly as you do. Yeah, so you can really cater that to each individual in front of you. That's exciting for me to hear. Thank you for explaining that. What would be some general symptoms that people may have one or the other physically?
Sure. Fatigue, brain fog, cognitive dysfunction of all kinds, headaches and migraines, anxiety, insomnia, sometimes depression. We can talk more about that later. And I see a lot of asymmetrical neurological symptoms that don't fit into any neurologic diagnosis. So asymmetrical numbness, tingling, weakness, burning sensations, ice pick sensations, crawling sensations, balance issues, visual snow, spots in your vision, losing vision in an eye for a moment, and unexplained rapid weight gain or loss is a big tip off.
What neuropsychiatric symptoms do you see most commonly?
So a lot of anxiety and insomnia, and then a decent amount of depression. And then in kids, we can see a lot more OCD and sensory integration, tics, that sort of thing. I mean, sometimes adults will get tics, but it seems more in the pediatric population that
Okay. What are the main causes? Obviously, the exposure to the mycotoxins and the mold. For the neuropsych in particular, is that primarily inflammatory based, or is there other factors that predispose the neuropsych symptoms with mold or environmental illness?
A lot of the mycotoxins are neurotoxins. So they affect the central nervous system and the peripheral nerves, especially the class of mycotoxins called trichothecenes. They attack the central nervous system. They can create all kinds of neuropsychiatric syndromes, including PANS, autoimmune encephalitis, and that sort of thing.
Okay. In terms of a treatment timeline, it sounds like you have a whole program based specifically off of these things, because a lot of people, I feel like you probably know, they come in and they expect it to be done in a certain number of months. But what might extend that, and how long can it take? How can we understand that?
This is my least favorite question.
Oh no.
I think it's everyone's, but it varies wildly. So it depends, on how much mold is in the system, how high is your, toxin load. It depends on how sensitive you are. So like somebody that can get up to full doses of binders and everything else, and within, a couple of weeks, they're going to move a lot quicker. And you can really only detox as much as the body is capable of. When we try to push it further than what it can do, it just mobilizes toxins, and it might move them to a worse spot than where they were initially. So you shouldn't be suffering. If your symptoms are getting worse, you back off on the dose and you go slower. So if you're sensitive, it can take, quite some time. But I always want people to hear is that even if it was to take a year or two to completely clear the mold from your system, you start feeling better like within a couple of weeks when you're on the right binders for your unique mycotoxin load. If you're no longer being exposed, if you're still in the exposure, you might not feel, the difference yet. But so it's not like it's like a year or two before you feel better. It's you're getting better the whole time.
Okay.
And
Yep.
I just go until we've cleared all the mold so that we can empty that bucket as much as possible so you can have more exposures and bandwidth within the world to live a more normal life.
Okay. And I would imagine it's tricky because everybody is so individual as well. In terms of what mold does to the immune system, something that we tend to ask about on here is immune support, and are there times when immune support could be added or missed sometimes in the broader community? And so patients hearing it, it helps them to know what to advocate for at their appointments if it's being missed. How does mold or CIRS affect the immune function in general?
Yeah, so it's a complete attack on the immune system, and it turns on all your inflammatory cascades. So you've got inflammation in the gut and the brain and the heart and the joints and in the muscles. You get inflammation everywhere, and then it turns down your good immune signaling. So then you get opportunistic infection. You'll notice when somebody is really mold sick, they'll get influenza, but they'll have the fever for 14 days. They'll get lots of other things. And then you can also have remote exposure to infections become opportunistic in the presence of mold. So, for example, you can have an old exposure to Lyme from when you were a child, and then you get in a moldy building, and the Lyme can become opportunistic in the presence of mold because mold is suppressing your immune system. And so then Lyme reactivates, and then you have the mold symptoms and the Lyme symptoms and maybe the BART and BAB symptoms, and it's all kind of a mess at that point. It has to be sort of teased out.
I like that you shorten the names too. It makes them sound more friendly, Bart and Babs. I do the same thing. Thank you for making it seem more pleasant for us. And so you're actually leading into my next curiosity topic. So you mentioned it assaults the immune system immensely. For you, is it important to support, or do you find that people need more an immunomodulation versus additional immune support?
I start with a very big blood draw that throws a very wide net. And so I'll be looking at their vitamin D levels and zinc and all of that and recommending the basics for immune function because they do tend to get more sick of other things as well. And then in Lyme, there's a big part of working on the microbiome, which is your biggest immunomodulator. And so we do a lot of, immunomodulation with Lyme.
Okay.
But in mold, just some immune support. I do a lot of things in the beginning that sort of strengthen the system in order to tolerate the treatment well, in order to feel good through the whole thing. Like the stronger I can kind of get the system, the better the whole process goes.
Essentially, you do a bit of terrain support and to get it ready for what's coming with the treatment. And do you have any go-to for favorite type of immune support for mold treatment? But also, I guess in the future, I'll ask you about Lyme and co-infections as well.
Yeah. In Lyme, it's a bit different, but it's just the basics really. A mold protocol is so. The thing about mold that I love is it's a great diagnosis because once you get out of the exposure, it's a beautiful turnaround. People do great. They don't feel worse. They get better. They get all the way better. It's a fun diagnosis. At the same time, it's a very complicated protocol. There's a lot of things you have to take and away from meds and supplements and on an empty stomach and da da da. So I try not to layer in 100 other things when I'm doing a mold protocol. So for mold patients, really just the basics of immune stuff. Vitamin A, D, C, zinc, probiotics are very, very helpful. I do IgG antibodies for some people.
Okay, yeah.
They're getting sick a lot. I'll do like a bovine IgG or colostrum, one of the products.
So might as well just go where we're headed there with the Lyme and co-infection as well. You mentioned immune support can be different in those cases. Do you want to? Are you able to tell us a bit more about that in terms of the differences?
I think I'll just start off with how I approach Lyme.
Yes, please. Good idea.
Yeah. The way I look at Lyme is I have an analogy and these numbers are made up, but if we did a good IGeneX test on a random sampling of the population in the Northeast, my guess is some 90% of people would have exposure to Lyme, which just means that their body has seen Borrelia, they've formed an antibody, and it's seen it. So the antibodies are positive for the bacteria, Borrelia. And then less than 10% of them are chronically ill. So I look at the why. What had it take your system down and not the other 80% of people or whatever? I believe that most of the time when you clear the things that allow the Lyme to remain active and chronic, the Lyme goes back into dormancy in a way. Sometimes I do all the work to clear everything in the terrain and I still have to treat the Lyme or BART directly, but a lot of times in the process, all those symptoms go away. But there's 5 things that allow Lyme to remain active and chronic in the system that are treatable. And I'm sure there's more, and I'm sure there's a lot that we don't know. But mold tips the balance more dramatically than anything else. And so basically, if you have mold in your system, you won't clear the Lyme. So in every Lyme patient that walks in my door, I test them for mold first. And if there's mold, I treat them for mold first, because a lot of times that can be all that they need. And if you treat the Lyme, you just have to treat it all the way until like the mold is gone anyways. And Lyme treatment can be harsh. You can herx and that sort of thing. And if you don't treat the mold, you'll just be on Lyme treatment forever. And so mold tips the balance very dramatically. Yeast overgrowth does. Gut dysfunction, because your immune system lives in your GI tract. That's your microbiome. So if you've got dysbiosis or other living in your gut that your immune system is trying to take care of, it can't handle the systemic infections that are happening. Gut dysfunction, and then high toxin loads, so heavy metals, environmental toxins, that sort of thing. Other things that are filling up your internal bucket, your total body burden, and then parasites. Parasites do it as well.
Do parasites also have the ability to affect the immune system's function as well?
Yeah.
We have all these things that really go after our immune function, it seems. Yeah.
Yeah,
Okay.
they do. Imagine, you've got a bunch of parasites, and what is your immune system doing? It's busy with those in your GI tract and wherever else it might be. Parasites are definitely one of the things that will allow Lyme to remain in the system and replicating.
You mentioned mold, yeast overgrowth, gut-brain access, toxins, metals, parasites. Did I miss any of yours in there in that summary?
Yeast. Did you say yeast?
Yeast. Thank you. Yeast. Actually, That's something of interest to me as well, the yeast overgrowth, because I think a lot of the times, and maybe even more so over here in my geographic location, it tends to sometimes not be considered as much. What can happen if we don't consider yeast overgrowth with mold or CIRS illness?
What I believe, what I've come to learn from doing this for a very long time, is that wherever there's mold, there's always yeast. They're both fungal, and mold will create all the right conditions for yeast to flourish in the system. And when you have water damaged buildings, there's yeast in those as well as mold. If you do plates for yeast, there's always yeast. And so what I have found is yeast can be a really big part of a mold case, or it can be a small part, but it's almost always a part of a mold case. And I don't know how big that part is until I get there and I start, treating the yeast. But I've had some cases where that was the biggest clinical turnaround, was when we hit the yeast and got that taken care of.
Is there anything in terms of diagnostics that are available to you within the functional world? Because there's not a whole lot within certain systems to test for that.
So I'll start off with just saying I don't need any kind of positive test. If you have mold, I know you have yeast, so we don't need to waste our time and money. But there is a lot of markers that you can look at. So I am on my initial blood draw, I do Candida antibodies. And if you don't have them, it doesn't mean you don't have yeast. But if you've got a positive antibody to Candida albicans, which is normal flora in the body, that tells me that likely you have an overgrowth, or you have at some point, in order for you to have formed an antibody to something that's normal flora in the body.
Okay.
So that can be a hint. And then you can sometimes catch it on a stool study. It lives in biofilm, so it doesn't often come out in the stool unless you do a biofilm buster for yeast.
Okay.
And then an oat test has several markers for yeast. Nutraval does as well.
All right.
And there's some other ways of testing it, but I don't go chasing the result with yeast so much.
That's helpful for people financially constrained too, right? So if you have the confidence, and the clinical decision making is so important in this process, if you have that confidence, then, exactly as you said, if somebody's not able to pay for it, why would we make them pay for it? You mentioned biofilms in there as well. And that's another thing that I hear commonly not talked about in the patient population throughout years and years and years of treatment. Can you explain to us how the biofilm itself works, what's inside of it, and why that might allow illness to stay long-term instead of going towards a remission?
Yeah. Imagine you're sleeping in a moldy place and it's humid and the mold spores are up in the air and sporulating, and you breathe one into your sinuses and it can attach, and then it replicates and has babies and creates communities, and they aggregate together and they form a colony. And then they secrete a glycoprotein matrix around the colony that protects them from our immune system and from our antifungal agents. So our immune system not only can't get past the biofilm, it can't even really see the biofilm. It doesn't know really what's inside. And the antifungals also don't get through the biofilm unless you do biofilm agents. So you won't get rid of all of it unless you do, biofilm eventually.
Okay.
Most people, occasionally they didn't form biofilm and you don't need it, but usually you do. And so it's kind of like the house that they live in that protects them.
Okay, good to know. So that sounds like something really big that patients may want to discuss at some point with their practitioner as well, so they don't miss that. Have you seen a patient with mold or CIRS illness that's just a very rare symptom that's not commonly on the main list of symptoms, but seem to happen as a result?
Yeah, there's a few. Frequency of urination is a common one. And then the static shock, you'll get more stuff like that. So there's also a lot of people get muscle fasciculations, which are like muscle twitches, but they'll get them all over their body. Whenever there's a really weird neurologic sounding symptom, I often think it's either mold or Bartonella. But I have a patient who, when he walks into a moldy building, he has the sensation of water going down the backs of his legs.
Yeah, I can only imagine some of the symptoms you've heard of. And is there any unusual ones that are less common in the tick-borne cluster? So Lyme, Babs, or Bart?
And there's a million unusual ones. Give me one of the bugs. How about
Let's do Lyme. Let's do Lyme first.
Okay, so some of the more unusual symptoms. So, I mean, the classic Lyme Borrelia is more like joint pain, achiness, flu-like symptoms. So they feel a little feverish off and on, and it's cyclical and phasic, and brain fog and that sort of thing. I've seen ticks. I've seen like kids like with big ticks from Borrelia. I've seen some people who had, what they called bipolar schizophrenia, and then it ended up not being, and it ended up being, well, it's actually more Bartonella than Borrelia.
Can you speak a little bit more about that? I'm sorry to derail you off your thought process there, and I'll remember to come back and talk about the rest of the infections. I got a note down here, but that's really impactful. You said there was mental health diagnosis, and it sounds like there was a root cause underneath that decreased those mental health symptoms. Is that, or?
Absolutely, yeah. New onset seizures, new onset significant neuropsych stuff. Bipolar, schizophrenia, that sort of thing can happen from Bartonella. I mean, a bit more as well, but an OCD and that sort of thing. But Bartonella is very suspect when, you're not, maybe you're like 35 and suddenly you start seizing or getting hallucinations.
That's very helpful. I'll loop back around to where I derailed you off topic from. We were talking about Lyme disease, the unusual symptoms, and then we're starting into Bartonella as well there. And then what about for Babesia? What are the maybe like 2 or 3 more common and maybe 1 or 2 unusual that you don't hear as often in the broader community?
The ones that are sort of unique to Babesia that make you more suspicious are shortness of breath, air hunger, hot flashes, night sweats. But Bartonella and mold have a lot of headaches and migraines, and then the BAB patients will often get like different kinds of headaches, like short, sharp ones, and more ice pick things, that sort of thing.
I might as well just jump right into the topic of encephalitis, because I'd imagine that shows up in your office often or depending on the day. Can you give us a patient listening friendly version of how to describe encephalitis for them?
I think what you're talking about is autoimmune encephalitis, and that's also known as PANS and PANDAS. So it's caused by an untreated infectious trigger. And then your body will make autoimmune antibodies to your own neurotransmitter receptors in your brain. So you'll have autoantibodies to your dopamine receptor, to your serotonin receptor. And depending on which autoantibodies you have, you get different neuropsych symptoms.
Okay.
Like certain will cause rage and aggressive behavior, and some will cause tics and cognitive dysfunction, and some cause OCD, that sort of thing. PANS and PANDAS is sort of more pointing at what the infectious trigger was for this autoimmune encephalitis. So PANDAS is from strep, from an untreated strep infection. And then PANS is other untreated infections, which is often mold, yeast, Lyme, and Lyme co-infections. It can be caused from other things too, but those are probably the most common causes. Autoimmune encephalitis, sort of the way that it presents. So PANS and PANDAS is the P stands for pediatric. But I will tell you, I've seen adults get autoimmune encephalitis as well. But the common picture is in kids, and it's acute onset. So like night and day, like you drop your kid off at school and they're a happy-go-lucky, affectionate kid with friends and and you pick them up and they're suddenly anxious and having panic attacks and having OCD, and they get aggressive and they have rage and they get separation anxiety. They start wetting the bed, they regress, all kinds of stuff like that. And that's sort of how it presents clinically, how it looks.
All different depending which area is sort of targeted by it, which neuropsych symptoms may present. So something that we're sort of working on here for the patient population is a bit of a HERCS, or potentially an encephalitis plan for what we would be the equivalent in regular medical world would be a PRN arsenal at home that's going to maybe decrease either the symptoms or anything like that. So far, we have very basic things added on there, like inflammation support may need to be increased during acute flares or HERCSs. Off the top of your head, is there anything else that might be helpful for a patient to discuss with their practitioner to have sort of, because a lot of patients, as you know, have cognition issues. So perhaps in a flare, they're not able to really think clearly. What am I going to do to help myself here right now? Do you have any go-tos that perhaps patients would add to their arsenal?
So in an autoimmune flare, it sort of depends on what the infectious trigger was. So if it was strep, you do azithromycin, shorter course of azithromycin. You can do naproxen twice a day for 2 weeks, can sometimes help. Occasionally, rarely we'll do some steroids. But if I know the infectious trigger and they're having a flare, then I can usually hit that thing and that can help as well.
Excellent to
And
know that.
yeah, and then there's a lot of things that you do regularly, but not in the flare, just to, decrease the amount of inflammation and
Okay.
yeah.
Okay, so it sounds like knowing the root cause of that, perhaps targeting that. Actually, you mentioned steroids, and that's a bit of a polarized topic as well. So I had to use steroids, and in the community, there's a lot of talk that people should not use steroids. So what is your opinion on that? How do some people still heal on a low dose of steroids and some don't?
So you're talking low dose. So I think the low dose steroid like Cortef, like, a small dose can help a lot of people that have significant adrenal dysfunction, either from the illness or from whatever. Usually at that tiny dose, it doesn't suppress your immune system. So the concern with a steroid is so it's strongly anti-inflammatory, so it can, decrease your inflammatory symptoms pretty rapidly and dramatically. But if it suppresses your immune system, then theoretically the bugs get stronger. And so why would you do that? But the tiny dose for most people can just really lower the inflammatory level without suppressing the immune system. And then in a flare, it's kind of the last ditch effort. So if all else fails and when they're really not well, then you can do a steroid burst, and often that'll take them out of the flare.
Thank you for clarifying that, because it's always difficult for patients when they mention that. They get a lot of sometimes.
It's difficult for us to
For
decide.
you as well. Okay.
For me, I'm always like, oh, should I do it? Everything else has failed. Like I always feel a little nervous doing it.
Yeah, it was actually my functional medicine doctor that put me on it as well, and she had the same hesitation, but it's helped me, so it's good to know.
Yeah.
I appreciate you really clarifying that for us. Do you have, in terms of binders, is there any pointers that you would give to patients or even practitioners listening about?
Yeah. So different binders have a different affinity for different mycotoxins. So the binders are chosen from your urinary mycotoxin test based on which mycotoxins you have. So for example, the trichothecenes that I talked about earlier that are the nerve toxins, probably the most pathogenic class of mycotoxins. The best binder for those is activated charcoal. And so like cholestyramine won't really touch trichothecenes.
Oh, okay.
Yeah. And then for gliotoxin, it's bentonite clay is the best binder. And so you choose them based on what comes back in your results.
It's interesting. I think I just heard you say something that may not be covered in a SIRS only protocol. Because I believe you said let me say that right.
The trichothecenes will not get pulled out by cholestyramine, neither will gliotoxin.
That's very important, actually. That's a very important factor, I think, anyways. I feel like you also do, so that's good. Do you ever have patients come to you who have experienced externally to you things like patient gaslighting or dismissal?
They've all had it.
That's
yeah, it's terrible. I mean, by the time they come to me, they've seen 20 or 40 doctors. They've seen all the specialists. They've had all the scans. Many of them have gone to Mayo Clinic, and they've been told over and over that there's nothing wrong with them. And I mean, I just wish that I could tell all my colleagues, just say you don't know. Just say, I'm so sorry. I don't know. I can't help. But quit telling them there's nothing wrong with that when they can't get out of bed and work, and they've got migraines and they've got whatever the things are. The medical gaslighting it's endemic. It's awful. Part of what we try to do is create a space that's safe, where they feel safe and they feel heard and seen, and because they have had that.
Yeah.
And my initial intake is 2 hours, and a large part of that is because I want to create enough time for them to really tell me their story, because most of them have never been able to tell any physician the entire story. I mean, I always say that my patients have medical trauma by the time they get to me. because they have their own trauma of life, and then they have their trauma being sick for however long they've been sick, and then they have the medical trauma from going to 100 doctors and them not being able to help them and telling them there's nothing wrong and do you want an antidepressant and that sort of thing.
It's unfortunate, but validating for the patient population to hear that, and to hear you speak on it in such a respectful way is also super helpful for our patient population to know that there are safe places out there. You get to be for them what you would want your son to have, probably would be my guess. Yeah, that's amazing. Thank you so much for working with our patient population.
Yeah.
We really appreciate it.
It just comes to you.
Yeah.
It's come and yeah.
Yeah. So what gets you the most excited about mold and CIRS treatment that maybe you don't always get the opportunity to talk or teach about?
For me, the most exciting part is that people really get better completely from mold treatment. Yeah, I just think it's a great diagnosis because people really do so well on it and they get all the way better. Treatment modalities that are interesting. I mean, there's lots of modalities that will also help pull out mycotoxins. So things like infrared sauna, ionic foot bath, lymphatic drainage, lemon in your water, coffee enemas, all that kind of stuff. I have a whole biotoxin relief handout. And so I have my patients sort of try a variety of them. And then whichever one leaves them feeling better afterwards, or detox baths are really easy, then they invest in them particularly.
Okay. So in short form, can you tell us what these things, mold, whichever one you want to focus on, or tick-borne, what do they do to our lymphatic system?
Well, they like clog it.
I've heard the word obliterated, but I didn't want to plant, I didn't want to plant something.
Right. So all of our detoxification pathways get full and the lymph gets sort of clogged. So total body burden is the concept of you have an internal bucket that you're born with and it gets filled with things throughout your life, exposures to plastics, pesticides, glyphosate, metals, biotoxin, mycotoxin, COVID, spike protein, all that stuff. And when the bucket overflows is when the system crashes. The nice thing about that analogy is that you can pull out any big chunk and ideally get the level down low enough to where the person can, be in life and functional again. And now I forget what the question was.
That's okay. I was so interested. I almost did too, but I actually have another quick one. So you mentioned long COVID, and this is not typically addressed in unidentified geographical locations, really hardly at all whatsoever. What does long COVID do to this complicating process? Does it affect the immune system as well?
Yeah, so I look at it sort of the same. So it's the total body burden and the bucket. And so the COVID spike protein with all the inflammation can be one of those things that tips the bucket. And so there's things that we can do specifically for long COVID, but a lot of it is really just trying to empty that bucket. We know how to treat mold and mycotoxins. So if it's a long COVID patient and they have mold, a lot of times when you treat the mold, they'll get better. And I think that's just lowering total body burden so that they have more bandwidth to deal with the rest. And there are specific things for long COVID, but I sort of approach it very similarly to Lyme, the terrain and all that. But after I do the initial things that we can do directly for COVID in case, because some people will respond to that and get all the way better too.
Do you see virtual patients? Can you explain a little bit about your practice, who can find you and how they can find you?
Yes, I have a functional medicine practice in Boulder called Boulder Holistic. It's boulderholistic.com. There's tons and tons of resources on there for Lyme and mold patients. I'm an MD, so I can only treat in the state that I'm licensed. So I can only treat patients that live in Colorado. And so I get calls from all over the country and all over the world. I do treat some international patients, but I can't treat most of those people legally and technically. So I created a online mold treatment course for patients who can't see me, who don't live in state, or who are international. And it walks you through a mold eradication protocol in a very sort of handheld, step-by-step, sort of safe way. It's really easy. I find mold easy to treat, but when people try to do it themselves, if you go out of order or you go too fast, you can make yourself really sick pretty easily.
Okay.
And so it kind of just walks you through the whole thing in a way that's sort of trying to make sure you don't make yourself more sick in the process by doing it. So I created that course so that other people could just get treatment and not have to come see me.
And I'm assuming that course ties in key points of both of your knowledge set, the SIRS and mold. That is amazing. So international clients, that's an option for them. And then you treat directly out of Colorado because you're licensed there. Is there anything that you could offer to the patient population to perhaps provide them hope? Do you see patients in your practice, healing and coming to remission? And anything along those lines that might be helpful for them?
Yeah, absolutely. I always say on every podcast that if you have mold, you should absolutely have hope. It is so treatable. The hardest part is getting yourself into a clean space, into a non-moldy environment. But from there, people get better. It's not even rocket science. People do really well with a good protocol and they get all the way better. You should absolutely have hope, and it's not in your head and you're not crazy.
We appreciate especially that last part in our community because it's difficult to contest the external gaslighting.
You are crazy. It's horrible.
Yeah. And it sounds like Terri has understanding of that. So if you're in contact with her, you mentioned you have an online program that people can pay for. So how would that work? And then do they have access to it for a certain amount of time?
Yeah, so that's Dr. Fox, themedicaldetective.com is the online course website. And the course, you have lifetime access to all 35 modules. They're very short videos, 35 different modules that walk you through, and so you can always go back to it. But it includes a lot of guides, like a big, extensive mold resource guide, and find a supportive physician guide and a biotoxin relief guide and all of that. And there's sort of two options. There's a do-it-yourself, which is $9.97. And then there's a VIP, which is twice a month Q&As with me.
Okay. Twice a month Q&As? Okay. Mm-hmm.
And I also wanted to say that I wanted to offer your audience a 15% discount.
I feel like the audience will accept that without contesting. Yeah, they accept. I accept on their behalf. So thank you so much for doing that. That's awesome.
It will be Your Lyme Matters.
So we'll post details about that. And thank you so much, Terri Fox, for doing that for us. And I'm very cognizant of the time, and we've been very lucky to have you here for an hour. Is there anything else you'd like to say before we wrap up the episode?
Well, just thank you for the work that you're doing. I'm so grateful for everybody in this space. I think it chooses us. We don't, especially in the beginning.
I 100% agree with you. It chose me. I can't shake it off. It's here. It's in me. So yeah, I'm happy it chooses people like you as well. So that's awesome.
Yeah. Well, thank you for the work you do.
You're welcome.